Hello there. Happy Tuesday evening. If we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist to the core. Very proud of that. And the owner and founder of Re+active Therapy and Wellness here in the Los Angeles area. I join you a couple of times every week to share some of what we're reading and doing. And I love it. I'm doing it tonight because I actually go out of town this week, and I'm heading to New York City to run the New York Marathon. Super excited about that. And I leave tomorrow, which is normally when I hop on here live. I also got super excited and inspired by a question that one of my students from USC asked, which, by the way, I have the most amazing students ever. And I got to be with them in their third year last week, talking about functional neurologic disorders for the first time. Super exciting. And then I got some great questions, and particularly I got somebody who sent a case and said, there's pieces of this person had a diagnosis of dystonia, and she said, there's pieces of this that I'm wondering, is this functional dystonia? Is it not? Or is it both, right? Which happens a lot. Both happens a lot. It's complicated, but it happens. And I thought this was such a great question. So thank you, Carly. This video is for you and for everybody else. But thank you for the great question. And let's chat about this. So I did a post today. Let me pull that up first. So this is on our feed. So if you want to take a look at it, download it. I'll also put it in our newsletter this week. So if you are a part of our newsletter, you can get this. If you're not already, you can join at reactiveeducation.com if you're a healthcare provider, reactivept.com if you're a person with a neurologic disorder. But a very simple distinction between idiopathic dystonia versus functional dystonia. But again, there's times when we see both. This very common in movement disorders in general. So what we look at are these key areas from the onset, if there were precipitating events, the course of the disease, and what we see on clinical exam. So let's talk about onset first. In idiopathic dystonia, which, by the way, there are many different causes of idiopathic dystonia. There's genetic causes, there's task-specific causes. We might even see this in Parkinson's, although that I would call that a Parkinsonian dystonia. But typically we see this as a more slowly evolving over months to years progression. Oftentimes in functional dystonia, we see a sudden onset and, like at its most severe, sometimes fixed position of dystonia, or it's evolving over the course of a few days. Now, by the way, these are kind of typical generalities. This doesn't mean this is the case for every single person. Precipitating events. So what might have happened before that? There's not usually an identifiable precipitating event in idiopathic dystonia, except in task-specific dystonia. So runner's dystonia. A lot of running, particularly a lot of running in a particular way, at a particular pace, on a particular course, under a lot of stress. So repeatable behaviors with a lack of variability and and sometimes under a stressful environment. This can happen in musicians. That's more often the precipitating event. Whereas in a functional dystonia, we'll actually see it more with trauma or some sort of injury. Not always the case. Sometimes it's an accumulation of things, and that's not fully understood. The course, though, is in idiopathic dystonia, it's very rare that it just spontaneously goes away, like a remission, and you might see a slow progression. Although if you've got good therapy, no, we can stop it and you can actually have recovery, yes. Whereas in functional dystonia, you can see a very rapid progression to a max severity and periods where it goes away. In the clinical picture, so what would we see clinically? And this is what I, asked Carly when she asked me that question. Is there a repeatable pattern of muscle contraction? So if that person has cervical dystonia, always looking the same muscles are overactive. We would even use surface EMG to see that muscle activity. Or is it variable? Sometimes sternocleidomastoid, sometimes splenius, sometimes semispinalis, sometimes levator. If it's variable pattern of muscle contraction, or, maybe it even changes limbs or sides of the body, that can definitely happen, as well as attention changing the symptom. So this is really interesting. In idiopathic dystonia, sometimes when the person's really concentrating, they can control it, thinking about it. In functional dystonia, when the person's often, now this is not always the case, I've seen exceptions to all these rules, but excuse me, often what we see is that when the person is attending to the movement or attending to the muscular contraction, it actually gets worse. And if the attention is brought away for automatic movements, the movement or the control gets better. Which is how we can treat it, is to unmask some of that automatic movement, which is phenomenal. So I want to give a couple of resources here for you because there's so much in this area. I love it so much. I want to bring up this one here. This is actually one of the slides from our dystonia mini course based on a lot of the resources that I put together in putting together a mini course that looks at the different things that kind of favor an idiopathic dystonia, some of what I talked about, favor a functional movement disorder, favor even another neurologic disorder, and something that might be consistent across all types. So I think this helps us kind of, when we see that presentation of dystonia, we are thinking of all of these things. So, for example, favoring another neurologic disorder would be like if we're seeing dystonia plus spasticity, plus lesions on an MRI. This can happen post-stroke, post-brain injury. Even years down the line, we've seen cases where dystonia has developed after the initial injury. Those things that are consistent across all types. So I think this is really important because sometimes I've had people go, well, I notice it's worse with stress. So is that functional? No, that's not the definition of a functional neurologic disorder, just that it gets worse with stress. So worsening with stress can actually happen with any neurologic condition. Spasticity after stroke gets worse with stress. Tremors and Parkinson's get worse with stress. And dystonia and idiopathic cervical dystonia, it gets worse with stress. This is why it's so helpful to have an OT on your team who works on stress management. Hey, we're all going to encounter stress. We would just like our neurologic symptoms to not get worse. So how can we manage that stress? All of the types. So somebody had actually asked this question. I saved some of the questions. Let me pull them up. People sent questions. Thank you so much. That was so amazing. Let's see. I think I have them in here. Well, I'll pull those up. But somebody asked a question like, can idiopathic dystonia get better? Any dystonia can get better with therapy. We've got evidence for it, small trials mostly, because dystonia is not super common and it's very heterogeneous. But it can absolutely get better with therapy. Idiopathic dystonia, functional dystonia, dystonia due to Parkinson's, dystonia due to a brain injury, absolutely all of them can get better with therapy. So that's very, very good news. I wanted to bring up, so by the way, that was a slide from our dystonia mini course coming up. So if you're a healthcare provider, our course is next week. It's actually the day I get back from New York City. So we're done. That's one of the slides. We put it together and we're so excited. So Chelsea Richardson and I will be presenting it just next week. So there's still room. If you want to join us live or catch the recording, you can. And you can do that at reactiveeducation.com/dystonia. Now, I recognize this is really tiny, and I've got the article pulled up here. This article from Stephen and colleagues in 2021, it's free, full text. I'll put it in our newsletter this week. It's called Functional Dystonia, a Case Control Study and Risk Prediction Algorithm. If you know me, you know I love a good algorithm. So I was super stoked to find this article, and particularly this little algorithm. So let me walk you through this. What they did was look at how can they, in a large sample, this is large for dystonia, 198, how can they get better at actually defining a person that has functional dystonia. So the first question that they ask, are there periods of resolution and reoccurrence? Those with yes, look for functional dystonia. Those with no, let's go to the next question, because not everybody has these periods of resolution and remission. Next is abrupt onset. Yes or no. If yes, look for functional dystonia. If no, go to the next step. Then you apply the risk score. So this is them looking at some of the other factors in the history, and a score greater than 3, look for functional dystonia. Score less than 3, less likely that it is a functional dystonia. So let's talk about those common exam features. And this is a lot of what I put into that summary table, by the way. I didn't make up that summary table. Well, I did make up that summary table, but I got that information from the literature. I didn't make up those signs and symptoms. This has been shown over and over again in the literature. So these are the pieces that they look at that are suggestive of functional dystonia. I'm so sorry. I struggle with my words there. General limb cranial with his hemifacial, blepharospasm, and paroxysmal. So in the general, what they look for and found is inconsistency and variability, provocation on exam, atypical sensory tricks. So that's another thing in an idiopathic dystonia, is that there's usually a sensory trick that the person has found, and a sensory trick is simply a sensory cue. A very common one, for example, if somebody has cervical dystonia, they'll put their finger on their chin and they can control the movement a little bit better. And having other functional symptoms. So other symptoms outside of the functional dystonia. The fixed dystonia, the dystonia at onset, this is for the limb. Foot dystonia with plantar flexion inversion, toe curling. These are common patterns in functional dystonia. Now, some of these are also really common in Parkinson's. So we would want to tease that out. And that's why somebody with dystonia should absolutely have a movement disorder neurologist. When people contact me, that's one of the first questions I ask. Do you have a movement disorder neurologist? Because they can get to the bottom of this from a diagnostic standpoint. Hemifacial dystonia. This is another thing. Some of our therapists work a lot with people with facial dysfunction. So alternating spasms from one side to the other. A lower facial spasm at onset. That's something that I've definitely seen. A lack of synchronicity in the spasm. There's the same kinds of things in blepharospasm. So asymmetry, alternating spasms, normal eye blink between the spasms. And then even stuttering speech during an episode of dystonia is one of the findings that they had in functional dystonia. Some of the other things are pain on presentation, though that can absolutely happen in idiopathic dystonia, especially in the cervical spine. A physical precipitating event is very common in a functional dystonia. So like an injury, a muscle strain, something like that. Sometimes a broken bone, all of those things. Really interesting. Some of the other things they found, I have not exactly seen this, but medication allergies, I think that's interesting. It tells us a little bit about the accumulation of immune and neuroimmune responses. I find that really fascinating. Dystonia at rest, at onset. So oftentimes in idiopathic dystonia, we see that dystonia start to occur first with movements and stimuli. So anyway, really, really fascinating article. And again, it's called Functional Dystonia, a Case Control Study and Risk Prediction Algorithm. I'll put it in the newsletter this week. If you're already on our email list, you'll get it on Friday. If you're not, join us, healthcare providers at reactiveeducation.com, and people with neurologic disorders at reactivept.com. But I got more here because people had asked questions. I took the names off of them, but I don't believe that you can really read those. Can you? Oh my goodness. Okay, so the first question here, and I wanted to make sure, let me stop sharing here. I wanted to make sure that I got to all of the questions. So I want to make sure I can pull these up. The first question really was the person asking, is there hope for me when I have idiopathic dystonia? And absolutely, as I mentioned, there absolutely is. We work with a lot of people with idiopathic dystonia, cervical dystonia, task-specific dystonia, genetic dystonia, focal hand dystonia. I mean, every type of dystonia, and there is a lot of hope with therapy. Absolutely, with therapy. Okay, and I'm just trying to pull up these questions because I really want to make sure that I get to them. And I hope that I can see them on here. I'm not sure that I can. Let me try to pull these up again here. So, so that was the first question. Oh, another really great question that somebody asked. I'm just seeing part of it, but any correlation between occurrence of cervical dystonia and vestibular migraine? Brilliant question, because one of the things that we look at when somebody presents with cervical dystonia is their vestibular system, because you can imagine if you have any asymmetry of firing in the vestibular system, you are actually sending the message to the brain that the head is turning, right? So depending on where that misfiring is. And if you are getting that, you actually can get subsequent muscle contractions or over contractions that can drive dystonia, maybe in the other direction, right? So there have been a few studies actually looking at this. Things like subjective visual vertical are important to test. But yes, we have seen vestibular dysfunction as part of the underlying issue in cervical dystonia. We've also seen that cervical dystonia can cause some things like cervicogenic dizziness. So this is why I think if you have dystonia, it's really important to work with a therapist that understands the nervous system and the complex integration of vestibular and other sensory inputs, somatosensation, vision, and how those are integrated together. Because we know in dystonia, the integrative function is off. So great question. Thank you for sending that. And then, oh yes, one last question. And this was a treatment question that somebody asked. And they asked if one could overtrain when treating dystonia. And I thought this was such a great question. There's some insight there, because overtraining can cause dystonia, especially in the focal dystonias. Runner's dystonia is a really good example of it. People that only run a couple minutes don't get runner's dystonia. People that practice instruments casually for a few minutes don't get musician's dystonia. It's the over practice that kind of drives the neuroplasticity gone awry. So, The question then comes, when we do training, when we do rehab for dystonia, could you overtrain? Could you do too much of that rehab? Now, it's hard for me to say, like, could you do too much of the rehab? But what I will say, one of the things that is so important in dystonia treatment is variability. So for the person, if you're like me, I kind of have my running path and I go a particular way, and I can really get kind of stuck in that way. If you're that type of person that tends to thrive on routine and organization and do things the same way over and over, you can, and I'm not saying I'm going to get dystonia or you're going to get dystonia by any means, but you could set up for neuroplasticity gone awry that way. Sensory smudging in the sensory cortex, for example. So one of the key principles that we use in our therapy when we're doing rehab for dystonia is variability. So we may have key practices that we use. So we may have sensory training, we have motor control training, we may have automatic training, we may be focused on particular lifestyle concepts. We're going to introduce variability into those routines. Lifestyle is such an important part of treatment. We haven't even gotten to talk about that a lot, but this is a big part of our OTs being a part of our dystonia programs. Because I would say training without sleep, training without great brain healthy diet, training and rehab without stress management, training and rehab without a good pacing through the day and variable activity, I don't think is helpful. I think you need all of those things. And if you are looking to put together a program, like this person asked me, like, could I overtrain? You want to train on the right things, for sure, and make sure you have some variety. I'm saying this, by the way, because I know I'm responding to questions. This is not medical advice by any means. And I know I say this a lot, what's helpful for one person could be harmful for another. So doing these things with your provider is really the best way. And that is why I'm here, is to empower all the providers in the world with this type of information so that they can help their clients. Thank you so much for folks that sent in questions, and I'm just scrolling through to see. Again, if you have a question, you can put it here in the comments, send me a direct message. I love your questions because then I get to do a video and answer them and talk about them. And again, tonight we talked about this idea of idiopathic versus functional dystonia, but often we see an overlap of both in people. And this is a big component of what we're going to talk about in our dystonia mini course. Our mini course is coming up. It's next week. It's November 10th. It's live, but it'll be recorded. And we're going to go through all of the background, pathophysiology, assessment and treatment in Parkinson's, in focal dystonia, in cervical dystonia, in so many ways. And we give a ton of resources. So cheat sheets for evaluation and treatment and helpful treatment videos to really get you on the path to having great success with people with dystonia. So if you are a healthcare provider, I highly recommend this course. And somebody asked, can patients take the dystonia mini course? So great, you're a medical exercise specialist. That's phenomenal. And you have runner's dystonia. Not phenomenal, but very treatable. We've seen people completely get rid of their runner's dystonia. I don't really recommend this course for the non-therapists. PTs and OTs are great for this course, but we're diving in at that baseline level of knowledge of the nervous system that most PTs and OTs already have, and we're going deeper. So this is, it's gonna give you the basics of dystonia, but it's definitely going deeper. So I'm not gonna tell you no, don't come to the course, but it's definitely not designed for the person with dystonia. Now, I'm gonna be here every week on this channel to answer questions. Of course, I can't give individual medical advice. We can't do that in our course anyway. And I would never restrict anybody from getting this course. And kudos to you as a medical exercise specialist. I think there's probably a lot you can learn because, hey, you are probably really in the position to prevent dystonia for people. That's another, a big one of my soapboxes is I think we can prevent some of these things. Overuse, dystonia for sure, some of the functional neurologic disorders I actually think can be prevented. Another great question coming in, awesome. So dystonia and functional symptoms. What to educate about expectation of rehabilitation? Great question, because expectation is everything, right? That's probably why you asked that question, because it's everything. So here's what I say when I see somebody with dystonia. The first thing is I think assessment is everything. Doing a super thorough assessment here, I'll stop sharing here. Doing a super thorough assessment is like that is your cornerstone or your keystone. What's the right word there? It's the big piece for you. And in that assessment, if you can actually piece through okay, this is the idiopathic cervical dystonia. You have overactivation of your sternocleidomastoid. It's at this level. This is the surface EMG. We see underactivation of every other muscles. This is why you're turning your neck. This is why you have a tilt. That it's reproducible. It's the same. It's worse here. It's better here. That's the idiopathic dystonia. However, we also see, and you've told me that there's these other factors that influence or make it worse. Sometimes maybe it tremors when you're exposed to a lot of sensory stimuli. When your autonomic nervous system changes. So maybe in a fight or flight state, for example. Those components where you get tremor, where you get a change in your movement, where I see that if we change your attention to something else in an automatic movement, it gets better. That component of your dystonia might be functional. And the good news is that both respond really well to therapy. And we know what it takes to help somebody get better. We have small amounts of evidence. So I've shared that. If you haven't seen that video, I shared, was it last week or maybe the week before, that phenomenal study by Nancy Beal and colleagues that showed that evidence of people having great improvement and returning to their musical instruments and returning to the use of their hands with dystonia. So we know that people can get better. And that's the case in both idiopathic and functional dystonia. And the good news here too, if you've seen our pie charts, there is huge overlap in those pieces of pie: sensory, motor control, autonomic, physical limitations, lifestyle, psychosocial. So all of those pieces address both idiopathic and functional dystonia. So then our expectation of rehabilitation is really positive. This person can do really well. Might not even need a ton of therapy, might just need 2 weeks of intensely practicing, or a longer drawn out therapy period where that person can practice on their own. So yeah, great. Thank you so much for that question. And I think we can set up a really positive expectation for improvement with rehab for dystonia. So thank you so much for the great questions tonight. Thanks for sending questions. So again, send me a DM anytime so that I can hop on here and answer your questions and help give you the tools as a healthcare provider to help people with dystonia, or as a person with dystonia to advocate. Share this video with your healthcare providers, advocate for what you need, and be educated. So thank you so much for joining me tonight, and I will catch you next week when I get back from New York. Have a great week. Thank you.